So I appreciate the opportunity to speak. It's like it's a reasonably small group. I'm just looking to see who's on, and I wonder if it kind of lends itself more to a discussion more than a presentation. Um, if people have comments, feel free to put it in the chat. If you want to just speak up and ask questions or bring up some things that have been maybe plaguing you in your efforts. Just bring them up as we go, and let's see if we can like turn this into a little bit of a forum where we can share and try and troubleshoot together. Sure, there's a lot of expertise on this call here. All right. So I thought we'd start by just thinking like, what does an ideal POCUS program even look like? If you're stepping into a role and somebody said, here are the keys to your POCUS program, what would be there? I'll sort of pause and people can speak up, or you can just put some ideas in the chat, and maybe Lubina, you can help monitor the chat as we do this.
I'll monitor and I'll kick things off. I'll say multiple trained faculty who
Yeah,
can help teach trainees.
definitely.
And then image review and feedback was just put in the chat.
Yeah, so there'd be some system in place for image review and feedback.
Equipment.
Equipment. Yeah, right. We'd walk in, there'd be like just like tons of options, some carts, some handheld devices. Yep. Yeah, billing, right? There'd be some workflow in place for revenue capture. Definitely, and that would be easy and not a headache to establish that. Training pathway or guidelines, a QA process. Yeah, some outline for, training people that weren't trained, that wanted to get trained. How do we do the QA? Yeah, I mean, I think all of these are great ideas and in the perfect world, this would it can make sense to us, right? Because we're POCUS people and we have an idea of what this should look like, and we want to put that idea to our hospital and be like, this just makes sense. So, give me the money to do it and make it happen. But I think the reality is for most of us, we're going to be building stuff from scratch, and it's going to be a much more sort of incremental process with some pain points that we have to overcome. But I think it's important to kind of keep in mind like where are we trying to head with this as we're developing our POCUS program. All right. So I thought I'd go through an overview of what we have set up at Yale for our internal medicine residents and our hospitalists. So you can kind of see the big picture of what we're doing here. Run through some key questions that either came up as I was setting up the program, or I wish I had thought about when I was starting the program that I thought about along the way, or I'm thinking about now, and some mistakes to learn from along the way as well. I I try to stay on top of the literature around this stuff. I've every couple of weeks, I get some update in my email box about the papers that have been published. And there's so much literature out there right now on people publishing what they're doing and what their POCUS program looks like. And it can be a little bit overwhelming, and it can also make you feel like you're not doing a good job where you are. But I think it's important to know that all this stuff is like, rarely presents like the challenges that have come up, and they're sort of best case scenarios. But of all the like the hundreds of articles that are out there, as you look through, they all kind of boil down to a lot of the same stuff, and they boil down to residents really value point of care ultrasound. So I haven't seen one paper where like the resident satisfaction with the POCUS program that's been worked on hasn't been anything other than stellar, right? And so residents really value having POCUS training. Um, the studies that are out there generally show that when you do an intervention, that resident knowledge and skill improves, right? That makes sense. I think what gets left out of that piece is the longitudinal part, and there is some evidence to tell us, and I think it makes sense that if you don't have a longitudinal mindset for this stuff, skills deteriorate, and so if you have an eye towards doing sort of short-term workshops, it's good to sort of boost a little bit of confidence and some short-term knowledge, but skill deteriorates over time, and so I think we want to have an eye on a longitudinal piece to whatever program we're creating. Residency program directors generally want it. Now, I haven't seen a lot of literature coming out of the PEDS world, but certainly in the internal medicine world, when program directors get surveyed, they identify having a POCUS program as being something valued and important. Now, whether that translates into protected time and budget to get it done is a totally different story, but at least when surveyed, this is something that program directors want as part of their training that they have available to their residents. There's a small bit of literature that speaks to this, that resident access without supervision is generally a bad idea. And so as you're thinking about your POCUS programs, cutting trainees loose with equipment in an unsupervised way leads to not necessarily more scanning being done, but more confidence without competence. And so that can lead to some problems. And so as you're thinking about building your POCUS programs, having some thoughts on how you're going to supervise is an important thing to be mindful of.
Joe, can I ask a question about
Yeah.
residency PDs? So I think when they say that they want it, like it seems like a very, like a very clear, like, yes, of course. Do you know, is there a sense of do residency PDs also know the time commitment it takes? Because I think sometimes, and like we've talked about this, I think sometimes they want it, but maybe don't always realize that it's a little unique compared to other things that are learned in residency in terms of like the time that it takes and the longitudinal piece that's expected too.
Yeah.
Do
Generally, no. I would say unless it is a POCUS savvy program director, their understanding of what it really takes to build a program is limited, which is an opportunity for us, right? Because to really make this happen, I think there's a lot of educating of potential partners that needs to happen, and so that's an important piece to think about. They want it, but they also have a lot of competing priorities too. Residencies these days, man, the residents, there are so many things that they have to fit into their curriculum, and thinking about how do we build focus into that and get the curricular time for it can be a challenging balance. So I think it's a good starting point that residency program directors generally value it and want it. There's likely some educational stuff on our end that we have to do to make sure that they understand um, that to meet certain goals like competency goals, it is a time commitment and a financial commitment as well. Um, this next one, faculty are hard to reach. I initially had this as faculty are hard to teach, but then that seemed a little seemed a little negative. But um, I think it's important to keep in mind when we're building our programs, like who are the faculty people, who are we developing, who are the next generation of educators. But once you're in a faculty role, it gets really hard to take this on, similar to what we just talked about, Libina, with it being a time commitment. Um, we all know that to really teach this and use it clinically, there's a lot we commit to developing our own point of care ultrasound skill set. And so it gets harder for faculty to be able to commit that time, and sometimes we have to be really creative about how we engage with faculty level people in terms of training.
Julia also, just on a related note, added in the chat, there's also a bit of a gap being created. More medical schools are offering POCUS training, as many as 70%, but fewer residency programs are offering significantly fewer on peds, especially now with our ACGME changes. That kind of took away a lot of inpatient time, and a big training gap with fewer peds faculty having POCUS experience.
Yeah, I think that's a really important point. That actually comes up a lot in my like faculty discussions. Just concern from faculty about what do we do? Because students are coming into residency now with experience, and a lot of times the students and the early residents have a lot more focus, savvy, and knowledge than the attendings, and that's something that needs to be thought about. How do faculty or traditionally in a supervision role who now know less than their trainees in this particular aspect of medicine, how do we manage that and deal with that? And it's definitely something that needs to be thought about. And I mean, if we have time, we can come back and sort of talk about some ideas around how we might think about maybe even a tiered approach to teaching faculty so they can feel more comfortable with that. Um, the literature points to a range of potential structures, a lot of ways to build a POCUS curriculum for trainees. There's a lot of like short-term workshop-based stuff that's out there. There are much fewer longitudinal programs that are published on. I think my takeaway from that is, whatever gets built, it's good to learn what's been done and what may be working someplace else. That stuff doesn't always translate to what's going to work for you in your hospital, in your program. So whatever you end up doing has to get individualized. And if competency is your goal in terms of your POCUS program, then really having an eye towards the longitudinal POCUS training path is the right idea. And the same barriers come up in every paper that publishes on barriers, and it's lack of trained faculty, limited equipment access, limited curricular time, and limited educator time. So even if you have trained faculty, they don't have enough time to support the curricula. And so the same barriers come up over and over again. And how you're going to deal with these barriers again, there's things that we can learn from each other, but there's going to be a lot of like institutionally specific things that are going to work for you. All right, so lots of literature, but I think those points sort of just boil down like hundreds of papers and what they say. So turning our attention now to what we've created at Yale, just to kind of give you an overview on that, so you can get more of a sense of where I'm coming from with things. I began working on this in 2011 when I was in my last year of MedPeds residency, where I really thought that this was going to be an important skill for me. I didn't know where it was going. And there weren't a lot of training opportunities for an internist or a pediatrician at that time. And so I really had to spend a lot of time developing my own expertise in point of care ultrasound. And the way I did that was, through a lot of courses. I went to a lot of different courses to develop some basic skills. There's online fellowships, online curricula that I participated in. But I think the most important thing that I did was identifying partners at my institution, so at Yale. And at that time, it was really just the emergency medicine folks that were doing it. And so I found a mentor, and I kind of latched on. I started going to the emergency medicine curricular stuff, and developing expertise that way. And so finding partners, I think, is a really key part to developing your expertise and, as we'll kind of talk about later, evolving your programs. In that time, there was a lot of sort of playing around with curricular ideas and doing some teaching, but I didn't really formally get into developing our curriculum at Yale until about 2015. When we started building the curriculum, I think through the work I had been doing, became obvious to our program director that, this is going to be an important skill for other residents to learn too. And so I was able to quickly get our program director engaged in it, and we were able to at least get some curricular time. Now, mind you, I'm still not getting paid for any of the stuff that I'm doing, and that's another thing too that just needs to be thought about as you're going. Like how are you sustaining yourself in what you're doing? And probably for most people, most programs, there's going to be some like volunteer, time that you have to do to start building this thing. And then once you get some stuff under your feet, then making an argument for protected time and thinking about the financial end. But it wasn't until about 2015 when we started, kind of formally building this out for one of our internal medicine residency programs, and it was a smaller program. And at the time, we really started just focusing on getting people exposed to point of care ultrasound. I would say a mistake I made then was probably trying to take on too much all at once. Having an eye towards everything that we can train people in and trying to incorporate that in, and I've since narrowed my scope and what I was doing. In 2021, we started individualizing our program, meaning thinking about there are residents who wanted exposure, and there were residents who wanted real competency. And the idea of trying to get everybody competency really was failing. And so we really started individualizing to those residents who really self-selected towards wanting to become competent in ultrasound and thinking about how we might develop a track within our residency program to get those individuals to the point of competency. And so 2021, we rolled out what we call our super user track, and we've been sort of evolving it since. We had 2 super users at that point in time, and now I think we're up to like 50 or 60 across the residency programs. And in 2022, we expanded the work that we were doing to involve, at Yale, there's 3 internal medicine programs. There's our primary care program, our traditional program, and our med peds program. And we started expanding it to those programs then. And in part, that was because while the other residents were seeing what was being done in our smaller program, and they wanted it too. And so they started voicing that to the program director, and then other program directors asked me to try to start building it to them. And it was sort of like getting that taste of what it can look like and what the residents want. That was when those other programs really got serious about making curricular time available and thinking about supporting with some protected FTE time to make it happen. And so this is what the actual curriculum looks like now at Yale for internists. So all of our interns get basic POCUS. This comes in the form of hands-on workshops that we do where we teach. Now, instead of trying to teach everything, we really narrowed it down to the basics, cardiac, lung, renal, and some procedural skills. And then after they get those workshops, we send an email out inviting residents to opt into our super user track. And interested residents who want to do the super user track, they're committing to creating a point of care ultrasound portfolio over the next 2.5 years of residency. They all have to do a point of care ultrasound elective in their PGY 2-year, and they have to become part of the point of care ultrasound community, either through teaching or through the development of some project, whether it's a QI project or a research project. And we do have a faculty development piece to it that we can talk about maybe a little bit later, but it's I would say that the faculty development piece has been slow. It's kind of been a slow trickle, and I think most of the faculty that we have now were actually just residents that we trained and then ultimately hired, right? And so having kind of a long-term vision for who your eventual POCUS faculty are going to be is important. Again, so this is what we do for just the basic intern curriculum. All the interns get this. And then for the super users, they develop a portfolio. And initially, we did this where everybody was in the generalist track. Everybody had to do everything that was expected of sort of a general internist skill set. But then, through the voices of the residents, they really wanted things to be tailored a little bit more to, some people are going to cardiology, some people are going to GI, and so maybe they don't need all of the stuff that a generalist does. And so we've created these different tracks within our super user track to sort of tailor the learning goals for the residents that are involved. And these are the expected number of mentored scans that they do over their 3-year period.
I love I love the idea of doing that more like kind of individualized track. Do you have trouble recruiting folks to do like kind of that mentorship piece of that for some of those exams, like for the quality assurance, or is that all on you?
It's mostly on me. So when I train, Scott, I really like my goal was to be able to do it all. So that was my personal goal. I love ultrasound. I love being able to pull my probe out and diagnose and manage, and I wanted to be able to sort of use that skill on whatever came through the door. So I personally kind of sought training. I would say that the hardest ones to get were things like the rheumatologic stuff, the MSK stuff. That was challenging. Some of the stuff we see less frequently that maybe the EDCs more like ocular, testicular. I really had to kind of seek that stuff out. But a lot of it does fall on me. But then um, building collaborations along the way has really been instrumental here. So, for example, when our rheumatologists wanted to start their own point of care ultrasound curriculum, I worked with them to develop that, and I contribute to that a bit. And in exchange, when I have residents that are really interested in learning MSK stuff, well, now I can call on them to say, all right, well, I've got some people that are interested here. Lubina is a good example of this too. As she was getting started, we did some training with her, and now when our med peds folks want more pediatric training, right? Lubina is gracious and takes them on, and so these partnerships become really important in terms of you know creating opportunities to specialize like this. A lot of the people not a lot, but a percentage of the people we've trained have gone on to cardiology fellowship at Yale or Palm Crit fellowship at Yale or GI fellowship at Yale, and now they're resources for our residents to use as well. And so there is this idea of building a community within wherever you are of sort of the shared learning experience, and uh, you want it to be a two-way street where you're offering something and they're offering something, and it's not just sort of a one-directional thing. But that's in part how we've managed to bring in sort of a range of expertise.
Do the faculty that help with your scanning sessions during the elective, do they also have protected time for this, or is it more volunteer basis?
Yeah, some do and some don't. So some of our faculty that mentor scans for us were former super users, and they recognize that in order to keep their own skill sets set up, like they need to carve out time to teach and do ultrasound. And so they're doing it for those reasons. We do have some faculty that we've been able to get some protected time for to be, help more on the administrative end, and part of that is doing mentoring scans. And through some partnerships with like our hospitalist program, who are really trying to kind of beef up the hospitalist work, they've made some stipends available for a couple of educators that we have, and so they don't have protected time, but they get a stipend for their teaching. One of the nice things that sort of come out of the super user track and this idea of sort of building community and sort of leveraging resources is that once you have a cohort of people that are, um, excited about POCUS and have some skills, getting them to sort of give back to the program in a way has taken a lot of that burden off of me to do. And so a lot of like the innovation that's come that we do has come from the residents that are part of the program. So it's just a few examples. So, expansion of the curriculum to other, IM residents within Yale. That was spearheaded by a resident who wasn't part initially of the initial work we were doing, but really wanted it. So, we brought her into the super user track, and then she sort of helped develop the curriculum for the residents that weren't getting engaged at the time. Um, Development of the specific tracks within the super user program, that was an innovation from our super users. They kind of wanted that, and I charged them with, all right, well, develop it, and then we'll make it happen. And then a really neat one that we're doing now, we have a resident who's really excited about street medicine, and she's spearheading a training program for our street medicine team to train them to use point of care ultrasound when they're taking care of the homeless population in New Haven. And so that's been a really exciting project. But just an idea of like, what starts with you all as the leaders wherever you are, empowering the people that you're training to really sort of think about, how do they give back to the program that you're developing and develop innovation and how you can support them to do that really leads to some interesting innovation. I think one thing that's important to think about as you're developing your point of care ultrasound programs is to really think about how competency is being assessed along the way. The easiest way to think about competency is the numbers, right? And if you look at the EM literature and something others, there are these numbers that are out there. You have to do 50 cardiac scans, you got to do 25 lung scans. Um, it's a little bit out of thin air, I think. We've looked. There's not a lot of great evidence to support one number versus another number, but it's easy. It's an easy bar to hit. So we do use numbers as a sort of a backbone for our training, but we're really trying to think about this in terms of overall competency. And you all know as teachers that you can have somebody who's done 10 cardiac scans and they're really good somehow, and then you've got others who've done 50 and they still stink. And so the numbers only tell part of the picture. And so we developed this entrustable professional activity based competency assessment where after every scan that our super users do, they get scored on this entrustability scale. And it's really pretty intuitive. I think we do this all the time as educators. We're constantly in a role where we're thinking, whatever the situation might be, do I trust this resident to go do this by themselves? And hopefully the answer is yes by the time they finish residency. But there's probably some point along the way where the answer becomes yes. You have a senior resident, right? I trust that resident now to go and evaluate, this unstable patient that we're taking care of on the floors, or I don't. I need to be there with that person to do that. And so we're doing this sort of entrustability all the time as educators. And so I just kind of converted that into a scale that we can use when we're thinking about ultrasound. And it's a scale of 1 to 5. And trustability happens at level 4, meaning at level 4, one is deemed sort of at the level where I trust you next time for this same patient to go and do it all by yourself from soup to nuts. You understand the limitations, the indications, you know the standard views, you're optimizing well, you're interpreting well, and you're integrating that information into clinical decision making in a way that I don't need to be there anymore. And the goal for our super users is they get to this point by the time they finish residency. Our goal for faculty is they get to this point by the time they finish, our faculty development program. But along the way, right, it takes time to get to that point. And so I think of a level one user as somebody who's like never had a workshop, never touched a probe, right? I need to be there. I need to guide the whole thing. I'm probably going to do most of the scan for them. A level two user is somebody who is getting some skills, but they still need me in the room to get the images to help them with their optimization. They're not quite sure how to turn that information into something that's clinically useful. So that's a level two user. A level three user is somebody who knows the indications, they know the limitations, they know how to get the images and optimize them, but they're not sure, they're still working on how to integrate it and interpret the information. And so I don't necessarily need to be there when they're scanning. They can go and get the images themselves, but I still need to discuss image interpretation with them and clinical integration. And then level four is they can do all those things and they don't need me. And what I like about this scale is that I can really direct the feedback I give to my level of trust. So if I say you're level two, my feedback to that learner has to be like, what does it take to go from a level two to level three? Well, it doesn't make a lot of sense for me to talk about clinical integration at that point. What I really need to be talking about is, do you understand the images you should have gotten? Are you optimizing well? How can you improve your optimization? Right? Once you get to a level three, you know how to do that. Now we start talking more about the integration, the interpretation piece. And so it gives me really tangible targets for giving feedback to residents. And I think it's a pretty intuitive way to do it. All right, so that's it's a bit of an overview of what we do. Uh, and now just sort of transition a little bit to thinking about some key questions that I either ask myself along the way, or I wish I asked myself along the way. Things that have come up, maybe things that you all are thinking about now as well. So definitely in this part, feel free to interrupt if something resonates and you want to talk more about it. So I think the first key question to ask is, what's the goal? Like, what are you shooting for? Are you trying to develop an educational curriculum where you're training your residents? Are you trying to create a clinical program where you're thinking about more along the lines of getting faculty trained, getting billing, organized, having, effective QA? Or are you thinking about doing both? I will say I think it's hard to do it all at once, and it may make sense to do it more incrementally. I think, looking at our own work, I think we've done a pretty good job of developing the educational elements of it. The clinical piece is something I'm still working on. It's something that's still in evolution. How do we take this work that we're doing and how do we translate it into like a revenue, um, and gaining functioning program. And so I think about the educational and the clinical as being separate but related. And as you're thinking about your own programs, like where are you putting most of your energies right now? I think the educational programming is a lot more obtainable initially. I think the clinical piece is a little bit more challenging because it really has to involve a lot more systems level processes that may be out of your control. An example of that is, for us, there's not a privileging pathway yet for people outside of the emergency medicine group uh, to do this in the hospital, and so it's hard to move forward with billing, for example, if we're not privileged to do it. And so there are pieces that we're working on lining up in the background, sort of evolving that clinical piece. But I think most people are going to find that clinical program development process to be a bit slower, and so I think it's important just to think about from the outset, what is your goal? What are you trying to accomplish? And putting most of your energies into one or the other, but not forgetting about the other one. Obviously, these things are connected.
And then related to that, when you're kind of convincing the hospital and yeah, mostly the hospital that this is an important thing that we should spend time on, have you had more success from the angle of this is improves quality and is becoming standard of care, or more success with this is potentially like a revenue generating thing?
Um, well, I think when it comes to like sort of the argument for privileging, the thing that the hospital has responded to most is the perception of risk. And without a standardized process for privileging, they don't have a lot of control over what people are doing in the hospital. It's a little bit Wild West. So I think from like an evolving interest in getting privileging done, sort of playing on the risk assessment side that the hospital is feeling with regard to undertrained people potentially using this as a tool for patient care. But for each individual thing, you can kind of talk about like what's the best strategy to try and push this forward. And I think it's going to be a little bit different for your developing your educational program versus developing your clinical program. And Lubina, you're keeping an eye on the chat, right? Just in case things are coming in.
Yeah, there was one that was for is your elective offered once a year or multiple times a year? We're trying to figure out how to schedule learning and training opportunities.
Yeah, so the elective we do is multiple times a year, and it's evolved as the number of super users has grown. And so when we had two super users, I just needed to run it once. But now that we have many more new super users coming in, I think we run it 7 times during the year, and I allow up to 4 residents per 2-week elective. I don't want the numbers more than that. I think it really dilutes the experience. So we limit it to 4, and right now we're running at seven 2-week electives during the year.
What are kind of the like nuts and bolts of that? Like, do you are they doing like asynchronous scanning? Or are they going into the hospital and then you're like reviewing the images after the fact, or are you there like supervising their scans?
Yeah, it's a combination of those things, Scott. So we start the first 2 days are a review. It's partnered scanning, so that everybody can at least hear how I personally approach the different scans, making sure that their technique is good, making sure that they understand what the standard views are for all the things that we're going to cover during the elective. That happens in the first 2 days. And then after that, everything happens in the hospital. The residents, they go, they find patients to scan, and I divide it into sort of morning session and afternoon session. And I try to have a mentor available for at least a half day session, right? So, today we're an elective right now, but I'm not there. The residents are doing independent scanning right now. In the morning, however, they were scanning with a mentor. And as you grow and your faculty grows, as the number of coaches available grows. And so initially I was doing all the mentoring myself, and now I'm able to farm that out to other educators, other POCUS faculty. And so it works because we have a range of people that can pitch in at this point. And the other thing too, in terms of like thinking about coaches and making sure that you have coaches available, you know, a percentage of those people that do the mentoring now are actually third year super users, right? And so they use it as an opportunity to keep honing their own skill. I think there's a correlation between those who are interested in point of care ultrasound and those who are interested in medical education. They seem to kind of run together. And so, they become third years and they're very interested in like honing their teaching. They're very interested in like honing their own skill set through teaching. And so each month I send an email out. I say, this is the electives coming up. Any volunteers to help teach? And we usually have a handful of upper level residents who are willing to come in and do some teaching during that time. So it's also a way to kind of share the load and the responsibility.
Are you during those 2 weeks doing mostly POCUS, or are you also in clinic or on the floors?
I'm not. I have clinics during those weeks, but I
Hmm.
try to do the elective when I'm not actively on service. I
Oh.
designed it initially that it could work if I was on service, but in the ideal situation, you wouldn't be. But that's not always going to be possible. So I think you want to try and design the elective in such a way that you don't have to be there all the time. And so there is a fair bit of independent scanning that gets done, and I end up reviewing those images asynchronously and sending feedback on those.
And
I also
so,
think that's like an important part of the learning. I think it's helpful to have like a coach there all the time, but you also need to be there by yourself, trying to figure out, where to put the probe and how to improve your image without the stress of having somebody looking over your shoulder, put, move to your left, fan. And so there is some value in the struggle also. So I think you can, as you build an elective, with intentionality, having independent time for residents to do their own scanning is important. Did you have a follow-up question, Libina? I think I cut you off.
yeah, it was sort of like a very small logistics question. So for planning this, when you get your yearly like schedule request from the internal medicine department, are there like 7 2-week blocks that you request to be sort of off to be able to do this?
Yeah, so the way it works here is they make this they build our schedules based on a prioritized list that we send them. And so I say, here are my prioritized list of inpatient blocks that I like to do. And then after that schedule comes out, then I schedule the elective time. There's a lot of coordinating, and your chief residents are really important here too, because it's the chiefs who are going to schedule the right residents into the elective time. And our electives, I used to make it available for everybody. It's only available for super users now. So it's just because you just couldn't accommodate everything, and I really wanted to focus on the residents that were on the competency pathway.
And then in the chat, somebody asked, have you used sonographers or radiologists to help with teaching?
Uh, we we don't, and no. So we don't use radiologists, but I think it's important to think about, like, at your institution, like who are the partners that you can partner with to do this. The residents will scan with, like, they'll go on the cardiology service and they'll scan with the cardiologist. They'll go on the, critical care unit and they'll scan with the intensivist. But they don't end up being sort of directly, sort of part of our coaching team. I think another question that you want to think about are who are your target learners? Are they residents, fellows? Are they faculty, hospitalists, APPs? And your program's gonna, has to kind of fit the schedule of the people you're targeting. And so residents and fellows are nice because they're captive learners. And so, they're in a learning role. You can set aside curricular time for that. Becomes a little bit easier. When it comes to faculty and hospitalists and APPs, you really have to think about, how do we create a program that works with their schedules? And I will say, for a lot of faculty, it's hard to come in like after hours to do scanning. So how do we make that sort of fit within the time that they're able to commit? So who is your POCUS champion? I think is a really important question to ask, and it's probably you all are the POCUS champions, but I would say it's probably not enough for it to just be you. I think a lot of the motivation towards improving our curriculum has really come from the residents, and having some resident champions who say, this is what we want. And so carve out time to make this happen. I think good program directors listen to resident feedback. And so if you have contingency of residents who are saying, we need this, we want this, that's going to carry a lot more weight than you saying to the program director, you should do this, this is important, you should have it. I think having those resident voices really come to the surface and speaking to their program directors about where they want their learning priorities to be is a real key to carving out curricular time for a POCUS program. Who are your critical partners and like who are the critical obstructors? Definitely something that needs to be thought about. When you think about partners and obstructors, I always think about like who are my partners now and who might my partners be in the future. And so, for example, I'll take it back to you again, Lubina. So when we, trained you and Nasheed, right? That was thinking like who might be, an interesting partner in the future. I think it's been nice now that we've sort of had this collaboration that we can move forward with. And so thinking about not just like right now, who can I partner with, but who might be a good partner in the future, that it's worth investing in their training. And then as it comes to obstructors, I would think about obstructors as just potential future allies. And so what is it going to take to move that obstructor into that partner column? For us, radiology was a bit of an obstructor early on. I would say having them just over time engaged in the process, and now they're an important ally in terms of moving privileging forward. And so thinking about like who those obstructors are and thinking about like the why might they be obstructing at this time, and really being targeted in how you approach that and how do you move them from a obstructor to an ally is really important. Sometimes that's showing data. So, if your program director is being, obstructing, giving you curricular time, showing data about where ultrasound is going, it might be an important one to do. If it's hospital administrators, it might be showing data on where billing can, really self-fund a POCUS program. And so leaning on data can be a really important way to sort of shift obstructors to potential future allies. And just so a note of caution as you're thinking about partners, ultrasound programs now, there's so many asks of them. Radiology was doing a lot of like training for different programs, and it got so saturated with asks for training that now they're charging people to come and train with them. And so you just want to be careful about asking too much. And I always think about it as like less of an ask and more of how do we create a sort of a bi-directional partnership. So if I'm asking somebody to help with something, I'm also offering, maybe if I'm reaching across to a different department, well, I can also help train some of your residents in X, Y, or Z if you can help train mine in something else. And so thinking about making that bi-directional, less of just an ask, but how do we turn this into more of a bi-directional partnership? Of course, you want to think about what resources that you have available right now. Try not to recreate the wheel on things. There's a lot of educational resources out there. I do very little didactic teaching anymore because there's so much online stuff, that I find it better with the curricular time I have available to just send the residents, give them a curated list of these are the things I want you to watch before coming to our workshop. And then just spending the workshop time doing hands-on activity tends to be more engaging and a better use of time. So there's lots of educational resources available. So, use those. Equipment's always an issue, but there's likely equipment that's available now in the hospital. When we started, we had one machine, that was it. And we've subsequently been able to grow, but we were able to get started with just that one machine. And then archiving systems, as you're thinking about, asynchronous review, QA, billing, think about what's already being used in your hospital system. It's much less effective to try and start something new. So our emergency department was using QPath for their archiving system. Now we're using QPath for our archiving system. And so not recreating the wheel on things, I think is really important. Um, and as you think about those resources, again, like who are your educators now that are part of your existing resources, but 3 to 5 years from now, who might those be? And like I said, a lot of our educators now are people that we trained, and that actually tended to be a much more effective. It took more time, but we have a much more, bigger stock of educators right now than we would have been had if we had just been focused on asking for like to hire, POCUS educators or grant FTE time for somebody. And so thinking about how your training can lead to educators of the future. And then a note on equipment, if you're really focused on getting that beautiful cart that costs, $80,000, you might not, it might be a long time before you get it, but handheld devices now, the technology is really good. You don't need a lot of fancy stuff to do most of the things that we're going to do with point of care ultrasound. And the price points for handheld devices are much more accessible. And I actually think the handheld devices from a training standpoint can be a little bit better because they're much more accessible than trying to find that cart-based system. Where is it? It's on a different floor. I got to go get it. I forget it. I'm not gonna scan. But if you have a handheld device that's readily available, it could be a much more effective option.
There's a question in the chat that I've been trying to read to be able to summarize, but maybe comes from me not being pet med peds. But there's a lot of med peds people here. I think about no matter what specialty, sometimes the clinical use and application and patient impact get lost. This seems especially true when thinking about extending to pediatrics. Many POCUS med peds colleagues bring their medicine POCUS expertise, like with cardiac, to the peds side. But for most peds focused providers, there are not enough reps clinically, especially within hospital medicine, that represent earnest clinical use. Wondering more about a true focused a la carte approach here. Have you had any thoughts on this?
Yeah, boy, there's a lot there to try and unpack. I do think it needs to be, anything you do needs to be individualized, and I think anytime you're trying to adapt something from somewhere else, you have to think about where it's coming from. And the true expertise lies within the people in the section that are building in. So I think if you're building a POCUS program, you really have to think about, how do we tailor this to pediatric learners and a pediatric population? I mean, most of the data on cardiac ultrasound that comes from adults and adult cardiology, IVC of 2.1, really in an infant? I mean, what's the right number there? And so you really want to think about, how do you individualize it for your particular group of learners? And that's where, this particular group of pediatric educators, it comes into play. I think there's more and more, conferences and courses that are pediatric specific and really trying to attend those and not necessarily the adult ones. It may be good to do both, but you want that pediatric element of expertise. I don't know if that answers the question, but you certainly want to individualize things to your learners and your patient population.
I
Is it
think
okay that we go over a little bit, Libina? I don't know if people need to jump off. I have a few more minutes, but I know it's like 3 o'clock, and yeah, I think we've been having a rich discussion, so it's okay that we don't get through all the slides, but I want to be mindful of time.
Yeah, Scott, what do you think? I was going to say, like, if people have to hop off, that's fine. But then
yeah,
if
we're
they're
recording, so yeah, I think that's totally cool as long as it's okay with you, Dr. Donroe.
Yeah, sure. Great. Um, So we're sort of kind of onward with the key questions, things to be thoughtful about. What are your existing institutional policies around POCUS? And this very much may be a moving target to try and figure out, but there may be institutional policies around equipment, credentialing and privileging, QA processes, billing and coding in our own institution, for example. And some people learn this the hard way, but there's certain handheld devices that the hospital says you can get and others that you can't. And if you end up buying one of those ones that they say you can't get, well, you might be in trouble. Um, you know, there may be some evolving stuff around privileging that you want to know about if you're developing a POCUS program, because maybe you can align some of your program goals around creating a portfolio that matches what that privileging is going to be. And so just sort of thinking about that. Now, privileging and billing aren't necessarily tied together, but at our institution, at least for internal medicine, they are, meaning they don't want us billing for things if we're not privileged to do it. And so that was important to know as we thought about prioritizing, are we going to start billing for things now? Well, first I have to tackle the privileging piece. And so just understanding what your institutional expectations are with point of care ultrasound is important. All right, some mistakes to learn from. I would say I think starting too big is a mistake. You want to think about feasibility. You want to think about your own time and how much energy and time you have to put into this. And you want to get successes under your belt. So I think if you try and start too big, it's a recipe for not evolving as quickly as you potentially could. So think about what's feasible to do right now, but where do I want to go 5 years from now, and sort of have those two visions in mind. I think not thinking through supervision policies is a mistake. One thing that will surely tank your efforts is, somebody who's untrained, who takes a POCUS device and makes the wrong call on a patient, and now all of a sudden there's a lot of scrutiny in what you're doing. So I think you want to think through what are your supervision policies as you go. Keeping track of equipment. People will only get trained if the equipment is available and readily able to be used. And so if they need to go if your residents need to go hunting down your POCUS, your ultrasound devices, it's just probably not going to get used. And clinically, you may know this from your own work. If you're working in a busy hospital or clinic, if you have to go try and find your device, it's really a challenge. And so making sure you're keeping track of your equipment and you have a method of checking things in and checking them out. Not being strategic with your free contributions. Like there's going to be a significant portion of what you do that is you're not going to get paid for, and that's going to be expected, especially early on. But you want to be strategic with it. And so thinking about, if I'm going to help train somebody else from a different department, well, how can I kind of leverage that to then, have that department also do some training for me. So be strategic with your contributions. It's also okay to say no to things as you're getting pulled in a bunch of different directions. If you're pulled too thin, you can't put the efforts into, what you're really trying to build. And so think about where you're putting your free efforts. Expect that there are going to be free efforts, but try and be as strategic as possible with them. And finally, I think it's a mistake to ignore your own skill set. You want to make sure you're putting time into developing yourself as your own point of care ultrasound expertise and your own expertise as an educator. And those things don't always go together. I think there are a lot more POCUS people than there are POCUS educators. And so, working on developing your skill set as both an educator and somebody who's clinically very good with ultrasound is important. So don't ignore your own growth and development. It also keeps things interesting for us. Great. And then so the last slide, just sort of final takeaways. I think as you're developing, your POCUS program, just it's an incremental process. Make sure you have like, what are my goals right now, and what are my goals, 5 years from now. Um, and just, understand it's going to be slow in most cases, but keeping things moving forward, and make sure you're always thinking about the feasibility piece. I think persistent champions often lead to success. And if you have POCUS champions that are residents and fellows that are the voices to the program directors who are in charge of the curricular time, that's a key piece towards evolving your curriculum. And then think about strategic bidirectional partnerships.